Andrea, I wanted to come to you next. You led the Ambassador study. This is a slide which I made at home last night. As you can see, it's not perfect by any stretch. In fact, I couldn't find your grade 3 or 4 treatment-related adverse events, which I know are there somewhere, but I couldn't find those. I apologize. I've summarized there a series of adjuvant trials that are ongoing. The first is obviously the NIVO 274 study, approved in all comers here in the US, only in PD-L1 positive patients in Europe. I put the OS signal up there, presented at the EAU by Matt Galsky, not statistically significant, but potentially clinically meaningful. And below there, I've got the Atezo ctDNA data. We're going to talk about ctDNA, so don't feel the need to go into the detail of that right now. But you can see here the 24-month disease-free survival rates, actually quite low, most patients relapsing from a disease-free survival perspective, in your study too. And then I put down that's the meta-analysis from GEMSIS of the adjuvant chemotherapy. What's your take on adjuvant therapy today and how it fits in with the context of the NIAGARA study?
Yeah, so a lot to talk about. I think that adjuvant therapy is active. Running the trial, I saw it firsthand, and then when I finally analyzed the data, I mean it was shockingly positive, and I say shockingly because we had the withdrawals when nivolumab was approved, and patients in the observation arm going to nivolumab. So it really confounded the outcomes. I don't know if we're going to be able to interpret the overall survival data, but it really is active. So do I think chemotherapy is active? Of course I do. I also think that chemotherapy is active, and if the patient did not receive cisplatin-based chemotherapy, I think they should. I think all these agents are active. I mean, when I saw the Checkmate 901 data in the metastatic setting, GEMSIS-NIVO being more active, it was modestly more active than just chemotherapy, I knew these trials were going to be positive because this is almost the same setting. I mean, you can argue that muscle-invasive disease is not metastatic disease, but you can argue that it is. So I'm not surprised that the NIAGARA study was positive. I'm really happy that it was with durvalumab because there's been a lot of concerns about the PD-L1s versus the PD-1s. And I always said they're all active. I know that it really depends a lot on trial design, patient selection, but I think honestly, I think all the checkpoints are active. I think it's the question you ask and how do you design the trial. So anyway, I'm really happy that the NIAGARA study was positive. I'm not shocked that it's positive, and I expect the rest of them to be positive too.
Petros, I want you to expand on Andrea's point. I agree with what she said. I don't think, we talked about adjuvant therapy being this sort of, or patients think of it, their cancer disappearing and suddenly coming back by some miracle, but that's not the case. They've just got minimal residual disease. We just haven't been able to spot it on an X-ray. And the reality is in bladder cancer, because it grows fast, it's just a matter of time. And that's why disease-free survival in this setting is so short. Maintenance avelumab has some parallels to adjuvant immune therapy, and 901 has some parallels to NIAGARA. Could you expand on that for me?
Great discussion. I agree with the points made by my colleagues and friends here. So I think number one, as everybody mentioned, it was a huge effort to complete the more than 1,000 patient trial in the periodic setting in the context of prior trials that had difficulty accruing. At the time the trial was designed, it was very difficult, of course, to predict the future, to be able to tease apart neoadjuvant or adjuvant or both. So the big question that your question implies is, do we need both? Or the adjuvant is carrying the weight of the benefit? A couple of thoughts on that. So number one, what do we know so far? We have the maintenance avelumab data in metastatic disease that shows overall survival and PFS benefit. So there is some value, I think, added, in my opinion, by the continuation of, in this setting, adjuvant checkpoint inhibition.
But to who, right? We don't know that.
That's a great question. We don't know to whom, because...
Is what you're saying that it's 4 months of neoadjuvant at the moment is too short for you?
So far, based on what we know and based on the trials, it's hard for me to exclude that neoadjuvant is not needed in some patients. I agree with Andrea, we need to know that.
Let's talk about what you said in your discussion, because in your discussion you said you wanted more detail of the PathCR patients.
Absolutely.
And in the prior discussion, in the prior presentation, the breast cancer group did present that PathCR data.
Correct.
Do you want to describe the data that you're looking for and maybe just talk a tiny bit about how ctDNA might be able to help too?
And I want to see it too.
Absolutely. So part of my wish list to Tom and the study team in my presidential symposium discussion was, can you give us an ad hoc exploratory analysis of how patients did disease-free survival, overall survival, stratified by the pathologic states, the accurate pathologic states. Pathologic complete response, defined as YPT0 and 0, pathologic downstaging, YPT less than YPT2 and 0, and pathologic residual muscle-invasive disease. I would love to see that in the NIAGARA trial and the subsequent trials. You are correct, Tom. We saw this snippet of data in the breast cancer keynote 522 trial, exactly before the NIAGARA. And to me, it was interesting because with long follow-up in that breast cancer trial, there's still uncertainty if the subset of patients with PathCR still benefit with the adjuvant pembro or not. I think the hazard ratio was 0.69 in the breast cancer trial for the PathCR patients with a very wide confidence interval, crossed 1. So I think that data will be very useful to see at NIAGARA. I know you will follow up the patient and see how these people do, because the critical question is exactly that. Do you need to treat everybody? We're going to over-treat patients.
But to piggyback on your maintenance analogy, you are giving maintenance to the responders, right?
That's
to the chemotherapy responders. So you would argue by that argument that they don't need it, but I guess we don't know, right?
Exactly.
And we saw in Javelin that PR/CR stable disease all benefited from the maintenance. So you might see that coming out as well. Those who get a PCR may equally benefit, right?
You can argue either way. I think you're right. We do not really know. Is it 4-dose neoadjuvant enough? Is it enough to have the long-term survival benefit, or you need that almost a year duration of treatment? And I don't think we're there yet to know. Would love to see data from NIAGARA based on the past stage. Would love to see data from other ongoing trials, Keynote B15, the GemCis plus minus Pembro, GemCis plus minus Nivo. I think the other nuance point here is, if you think about the NADINA trial in melanoma, that they did neoadjuvant versus adjuvant, neoadjuvant appeared better.
But that was Ipi-Nivo.
It was Ipi-Nivo, different treatment.
In melanoma. And that's very different from durvalumab chemotherapy in bladder cancer.
Of course.
And we spent a lot of time trying to repeat what we did in melanoma in bladder cancer, and I got really burnt when I did that.
Different tumor type, different treatment.
Let's be really, okay.
Tom, I had a question.
Yes.
How many patients in the control arm got subsequent immunotherapy at any point? Is that data available?
So the data is coming out with that. It's actually a very low number at the moment. And in both arms, subsequent therapy in all of these trials is lower than I would expect. There is some robust data from Checkmate 274 suggesting about 66% of patients go on and get subsequent therapy after adjuvant therapy. That feels very low to me.
But we don't know how accurate that is, right? That doesn't mean they didn't receive it. That's just what was documented.
And then this has got really low data too. But you think, so some people say, look, hold on a second, these trials were done in countries where there was no access to X, Y, and Z, and therefore, they should have all.
That's probably true too.
Partly, but everyone's got access to platinum-based chemotherapy, and so therefore, in the adjuvant trials, you would expect 90% of patients to get frontline metastatic treatment, and it's only 66%. And so this is one of the issues around clinical trials. We think randomized phase 3 studies are all truth, nothing but the truth, but actually it's only as good as the quality of the data we're collecting. And I'm concerned about subsequent therapies. We are going to present more around that, but the numbers are low, as we've seen in the other adjuvant trials.
And I think this was part of my wish list too, my last bullet point. Can we do our best, and you're doing your best, to capture subsequent therapies, adjuvant and metastatic, because this can have impact in the survival endpoint. The last quick comment, Tom, you asked about ctDNA. I think as we get data from all these trials, including the tombola we saw, we'll talk about the stratification at the cystectomy phase to inform our decision.
We're coming to it. Petros, one more shortcoming. So we talked about lots of strengths of this trial, but one more shortcoming that you put on your list that we haven't discussed so far. Anything that you think we haven't discussed around this trial that we should highlight to the group?
I think I agree with all the points. One thing that I think is worth discussing is a dose-dense and vac chemotherapy.
Can we come to that now?
Okay, great. Wow. Perfect.
Okay, here we go. So again, this was on the aeroplane on the way here with PubMed.
That sounds early, very early for you.
This is very early in the morning. This is a summary of the perioperative trial. So going down Atezo, that's obviously Abacus, then Pembro is Pure 1, TAR 200 is Sunrise 4, MVAC is the SWOG study, and then below that is dose-dense MVAC as part of the VESPER trial, GemCis Nivo, the largest single-arm chemotherapy neoadjuvant trial, then EV, SG, and DV toripalimab. There are some blanks there, and if you go onto PubMed, you'll see some of the data is different. So I've recalculated the path CRs using the denominator where I can. Sometimes I've not been able to do that. So this is the best I can do.
Right, because there were different definitions.
Everyone's got different definitions.
And different eligibility for a lot of these trials.
And different eligibility, which I put CT2 in there. So this study this is not supposed to be a direct comparison of where we are. This is just where we are. And you can make of it what you will. I probably should have a big caution, say, don't make direct comparisons. But my interpretation of this slide at the moment is that in the MVAC study, the SWOG study, 40% of patients had T2 disease. CT2, he's blank there, it's supposed to be 40%. That's what this NIAGARA study was benchmarked off. And that's why we have 40%, and that's why we capped at 40%. We wanted to try and reproduce that large trial. You can see here T2 being very variable. And you can also see the path CR rates being pretty variable, and I can see being non-comparable. And the 24 months event-free survival, being, again, very dependent on the patient population. Petros, what do you make of dose-dense MVAC? Well, no, Shilpa, let's ask you a question. What do you make of dose-dense MVAC? And do you think that, and how does dose-dense MVAC fit into the NIAGARA study? And Kala, same question to you afterwards.
So I don't really use dose-dense MVAC. If you look at the data across US, only about 30% patients get any neoadjuvant cisplatin-based therapy. So I think we have to do better at offering cisplatin and not be kind of married to just dose-dense MVAC. It is a more toxic regimen. Unless I have a very young patient, I don't. In the Vesper, they use 6 cycles of dose-dense MVAC. It's really not practical for us to expect in the community that we should be going and preaching that give dose-dense MVAC. I think we have to preach give cisplatin, no matter how, split dose or regular dose. So in my practice, I use only 10% of dose-dense MVAC, if at all. I'm very comfortable with GemCis and GemCis IO.
Carl, what's your take on this rather chaotic slide and how you have got to a position where you're treating patients in Toronto?
Yeah, I mean, I like your chaotic slide. It thinks it puts somewhat in perspective. Data. Yeah. And the variability and the sort of lack of harmonization is quite evident. But I mean, for me, I tend to agree with Shilpa. I use a lot of GemCis. I do use split dose, so I'm very happy to see it in the NIAGARA trial as well. Even in that setting, I rescan after 2 cycles just to make sure they're not having disease progression. I think it's about giving platinum-based chemotherapy, ideally cisplatin, whatever you do to do it well. I think that's the message. I don't split hairs between GemCis and dose-dense MVAC, and I have concerns about 6 cycles of dose-dense MVAC as well. I think the one point I'll say here, I'm curious about the TAR-200, where you have a device within the bladder, of course, that's eluting gemcitabine. Is a PCR
Can we come to TAR-200 in 2 seconds?
Okay.
We've got a specific slide on that. Before we get there, I wanted to just talk about ctDNA, and Andrea, perhaps you'd like to take this on. So circulating tumor DNA is gathering momentum. I haven't showed the Tombola trial data here. I've shown the data from IMvigor 010 and 011, which essentially shows using the Natera technique, but there are other methods that we could use too. But using this personalized technique, you can identify 40% of patients who are ctDNA positive post surgery, and those patients that are positive have about a 90% chance of relapsing compared to 30% of the negative. And this is the OS data. On the left-hand side, dark blue atezolizumab, dark red placebo or best supportive care, and you can see a benefit there. On the right-hand side is IMvigor 11. IMvigor 11 is trying to validate those findings. It may or may not be successful. It's completed its enrollment of over 200 patients. And on the right-hand side is just tracking those negative patients. And if you remain negative over a period of time, your chance of relapse is pretty small. Andrea, how is ctDNA going to change what we do moving forward? Does it currently have a role, yes or no? And what do you need to see to change your opinion on what's going to happen with it?
So it's available to us in the United States, and I don't like to get biomarkers that I don't know what to do with them because we don't have prospective trials, but it's hard for me to not get data if it's available, so we get it anyway. And then we're just kind of sitting around nervous for the patient because they're like positive and the scan is negative, and I sit around nervous, the patient sits around nervous, and this is kind of what we do. So I think this data is going to be so valuable as to tell us to be more aggressive with the patients. And what that is, we have to figure out what that means to be more aggressive. But I do think that we overtreat patients. And some patients don't get treatment, but patients that do get treatment, not all of them need it. And I think this is going to be a really important marker. I've been very impressed. There was a patient that was, for example, ctDNA negative, NED on the scan. We followed him. The ctDNA kept on going up. We're like, he doesn't have anything. This is driving us crazy. And then 6 months later, he's got carcinomatosis everywhere. And we were like, oh man, you know, like, would we have done something different at that point? He had already gotten both neoadjuvant and adjuvant therapy. I don't know what we would have done differently for him, but just in general, I think it's very accurate. I think it's really important to incorporate it prospectively, and I think it's going to really help us enrich our trials in order to treat the patients that really need the treatment and observe the ones that don't.
Does ctDNA analysis have any role in the NIAGARA study? So at the moment, if you, let's say you are post-surgery, you're ctDNA negative.
Absolutely.
And what is that role?
I think we need to do it in order to see the patients that, you know, how was the downstaging, how did it correlate with the ctDNA? We can learn more. And then the patients that went on to the adjuvant, how did they do? I think that's all going to be really valuable. I know it's retrospective, but it's going to be really valuable and informative for us.
What happens if IMvigor11 is positive? The validation study of the adjuvant setting showing that if you're ctDNA positive, you benefit from atezolizumab versus placebo. Do you think that would supersede adjuvant nivolumab in those patients that can't get neoadjuvant chemotherapy?
I think that it's important information, and a lot of people, when the IMvigor01 data came out, which is the adjuvant atezolizumab data, said, well, it's not an active drug. And I just think that it has a lot to do with trial design and what the endpoint was, and I think it is an active drug. I've used it in a metastatic setting, and I've seen some really nice responses. So I think it is going to be important. How does this fit in with nivolumab? I think these are all active drugs. I think it'll be another option. And we should really focus on treating patients that are ctDNA positive, I think, until we have other ways of assessing who really needs the treatment.
Kala, one of the issues is if you give neoadjuvant immune therapy, so in the adjuvant setting, I think it identifies patients who potentially are at risk, who potentially have MRD, and it's not perfect and it's not bad for that. The bit I like about it in the adjuvant setting is by the time you've got measurable bladder cancer, immune therapy, the horse has bolted as far as I can see. And that was the problem with Danube and the other trials, is if you give immune therapy to measurable bladder cancer, it just grows too fast, you never get control of the disease. MRD, if it's not yet measurable in that patient with a 6-month or 4-month lag period, the runway's longer to get control of the disease. And so I could see, had the neoadjuvant trials not been positive, this would have had a massive impact, because treating ctDNA negative patients with a relatively low risk of relapse may be a bit counterintuitive, providing these trials were positive. But in the neoadjuvant setting, when you've cleared your ctDNA, those are the winners. And you might say 3 months of therapy, if you're winning with immune therapy, the patient's going to come back and say, hold on a second, why are we stopping the drugs that were working? If they're ctDNA per surgery, do you think that's a conversation which patients will have? Or do you think they're going to say, oh, great, I'm fine, I need to move on? The question I'm asking is, if you clear your ctDNA, is 4 months long enough from a patient perspective, or do we need to keep going for the whole year?
I mean, I think that patients tend to want treatment more than they don't want treatment. I mean, we've seen that in the maintenance story. And I think a subset may say, okay, I've cleared my ctDNA, you know, I can be done. But I really think that there's a bit of a pressure to keep going with treatment. And I think we still need more data to understand what are the ctDNA dynamics. And, you know, up front, does the addition for your NIAGARA trial, does the addition of immunotherapy to upfront platinum-based chemo, does it help you clear your ctDNA better? And I think that'll be an important question that maybe ctDNA data will help us.
So what I'm hearing from you three is the ctDNA data are actually, we don't have enough yet, we're using it.
We don't have enough data.
And we can't make any hard decisions based off it.
But we do,
but we do, but we can't. And none of you are prepared to say, I would do this definitely because of that. And it all ends up being, we need to see more data. So this is all premature.